I'm Cornell Clayton, the director of the Foley Institute, and on behalf of the Institute, I want to welcome you out to our event today. Go ahead, come on in, grab a seat. Before I get started, I want to thank Mariana Amarim from the Department of Sociology, right there. She helped us set up the visit of our guest today, so we want to thank her. Our guests, we're fortunate to have with us today Emily Parker, who's an assistant professor in the Edward Bloustein School of Planning and Public Policy at Rutgers University in New Brunswick. She was formerly a postdoctoral fellow at the Population Studies Center at the University of Michigan, and she received her PhD in public policy at Cornell University. Dr. Parker's primary research interests are in how public policy and community context matter to the link between health and poverty, and that's what she'll be speaking about today. Join me now in welcoming Emily Parker to the Foley Institute.
All right, hello everybody. Thank you so much for coming today. I see some familiar faces for people I've met so far during my visit. Those of you I have not met, feel free to stay after and say hi. So in my research, I do qualitative, quantitative, and historical research to study the U.S. healthcare safety net. I do many different things in this regard, so I'm going to show you some of those different lines of research as we go, and I'm also going to tie in some current events and how the work that I'm doing is being affected by and being changed by what's happening in our current political landscape. So let's first go back in time to 1965. This is famously the year that under President Johnson, we established Medicare and Medicaid as entitlements for health care for low-income Americans, elderly people over age 65, and people with disabilities. So this was the first time in our history that we had widespread public involvement in the healthcare system. While most attention during this time was on Medicare and Medicaid, a lesser-known health policy was being enacted as part of the war on poverty. So in the Office of Economic Opportunity, this was the workhorse behind the war on poverty. We had the launch of what is now known as the Community Health Center program. You can see this part here. Other well-known programs from this time include Head Start, Up Top, Legal Services, Community Action Program, the VISTA program, et cetera. So this was a time of major social policy innovation. And the goals of the Health Center program at this time was very much in line with the humanitarian social justice values of the civil rights movement. The primary, come on in, it's okay. The primary goal was to provide free healthcare in high poverty communities. This was the overarching goal, so anyone could go and get free healthcare. Other goals included remedying racial and socioeconomic disparities in access to healthcare. They targeted interventions at the whole community level. So these were focused on what we now think of as the social determinants of health. This was a big focus even back then in the 60s. Come on in, it's okay. That's fine. They also were focused on community governance, so including local community members on the governing boards of these clinics. And they were intended to train local community members in the medical profession. So they were seen as a way to get people into the workforce. Here are some images of the first two health centers that opened, one in Mississippi here, and the other just outside of Boston in a public housing project. So these were the first two health centers in our country. By 1970, they had spread more around the country. You can see here, these are centers with operating grants versus planning grants. So it was a growing, emerging program, but still relatively small. When we got to 1990, it had started to spread more and more around the country, although you can still see big swaths in the middle of the country did not have access to any of these clinics. However, by 2018, and this has continued to this day, you can see the massive growth of this federal network of safety net clinics all around our country. So we have here almost the entire eastern seaboard has some access to a clinic, and still parts of the middle of the country are a bit lacking, but you can see it's grown a lot. This is largely due to the bipartisan political support of the program. I'm going to spend a little time explaining how we got to that point in a moment. But before we get there, just to give you a sense of their reach, they now serve over 33 million predominantly low-income Americans. This equates to 1 in 10 Americans, 1 in 6 Medicaid enrollees, and 1 in 5 rural residents. They also disproportionately serve racial and ethnic minorities, as you can see here in this graph, which compares the health center population in orange to the US population in blue. And compared with other safety net programs that are more well-known, they're also sizably bigger. So over 10 million more than EITC recipients, more than 3 times the amount of federally subsidized housing recipients, and 15 times greater than TANF or cash welfare. So this is a really sizable program around the country, but despite that fact, it's many people don't even know that it exists. In fact, in some of my own research at a rural health center, I also found that largely patients and even some staff had little awareness that this was part of a longstanding federal program. So this is part of what political scientists call the hidden or submerged state. So people interacting with government services, but not realizing that this is government, right? And so this is part of our disconnect that we're experiencing in this country, and kind of a lack of appreciation for the many things that our government does for us on a daily basis. In my research, I found that because people did not think of this as a government program, there was also less reports of stigma going to the center. Most people thought that it was just like any other regular private doctor's office, and they didn't see it as charity care or government. So this is a really interesting finding on what happens when we have private delivery of services that are publicly funded. So I'm happy to talk more about this, my qualitative research, in the Q&A, but this is just to give you a sense of what it is like for patients going to the centers, low amounts of stigma, but they don't recognize that it's government that they're interacting with. And one of my other findings is that patients often don't know that they have an ability to demand their rights to care for free because they don't think it is government. Anyway, happy to talk more about this in Q&A. To bring it a little closer to home for you all, this is a map of the health centers around Washington state. You can see in these yellow stars, those are the main grantee organizations, and then the red dots are satellite clinics associated with each of those grantees. So what may not be surprising to you all is that there's a lot more health centers on the western side of the state by the Seattle area, and you're all down here, I think, right? You're a little bit of a desert when it comes to federally qualified health centers. But around Washington, let's see, where's the number? You have over 1.2 million patients going to these clinics every year on an annual basis, and more than $136,000 of federal investments is going to these clinics. You can see here a little bit more about the services in your state. I want to point out to you that there are some special population groups that these health centers target. They include patients experiencing homelessness and agricultural workers. So close to 100,000 agricultural workers in your state go to an FQHC health center for their care. So going back to the bigger picture though, as I mentioned, the program has grown a lot over time. And you can see through this graph here that the funding and patients have started to increase around the turn of the century. This was largely due to President George Bush. He was one of the program's biggest champions, which may be surprising to those of us who were living through his administration. During this 2006 speech, President Bush said that the health center program is a really good use of taxpayer money. It makes a lot of sense. A few years later, President Obama further expanded the program first through the Recovery Act and then, of course, the Affordable Care Act. In the first year alone, they invested over $11 billion in health centers, so to grow the safety net clinics around the country. While many Republicans strongly opposed the Affordable Care Act, they continued to support the health center program. You can see here over 100 House Republicans calling for continuing to grow this funding. This was during the first Trump administration. This support continued under the Biden administration, despite the fact that political polarization was getting even stronger. So we see politicians, including my home state senator, Bernie Sanders, who's very progressive, finding middle ground with very conservative politicians as well. So part of my research has been trying to understand why we have this program that explicitly targets disadvantaged populations, but that is able to gain bipartisan support. And this is very unusual. I think all of us are aware of our political polarization. A lot of that centers around programs for low-income individuals. And so this is an unusual, deviant case from that typical pattern. So in my research, I compare the political history of community health centers with Medicaid. These two programs both focused on healthcare for the poor. They both were in the United States, started in 1965, but they differed in their political outcomes. So I think a lot of us may be aware that Medicaid is a highly polarized program, and we're always seeing it in the news and continuing to this very week. It's very much a contested program. So to how I study this is I've gone to presidential archives to trace the policy history and see how policymakers themselves are talking about these programs. I argue that in order to understand politics of consensus, it's even more important to get inside the room. So why are these policy elites agreeing? Why do we have powerful Democratic and Republican policymakers coming together? So I've been to all of these libraries, as well as George W. Bush. I can talk more about that later, to understand the policymaking, the divergence of their history. This is part of a book project. I'm not going to get through all of these today, but there are many factors that I consider when I'm comparing these policy histories, including institutional, political, and cultural and discursive factors. To give you a brief glimpse into just the first 10 years, we know from policy and political science research that early periods matter a lot when it comes to policy, both what's passed, how programs are implemented. So just the first early years, I'm going to focus on those now. They had path-dependent consequences for the future politics of both programs. So when we think about institutional factors, some really important differences between Medicaid and the health center program first had to do with their policy design. So Medicaid partners is a partnership between the federal government and states. So it's continuously encountering a lot of state policymakers who have what's called the power to make veto power. And so this is why a lot of contestation occurs when we have state-based policies. The health center program was housed within the executive branch. It was centralized. Fewer people had any say over the way that the program was administered. State policymakers were not involved almost at all. Medicaid was institutionally attached to AFDC, or welfare. So in order to get Medicaid in the 1960s, you had to already be on AFDC. And so this was, it kind of picked up a lot of the baggage of the welfare program. In contrast, the health center program had no association with cash welfare and was mostly delivered via, as I mentioned, private entities. So hospitals, community organizations, academic medical centers would apply for these grants. So this made it less public. And the initial budget estimates for Medicaid were far surpassed almost immediately, whereas the health center program did have a smaller budget. These all mattered. In terms of the most important political factors, Medicaid had very little elite support from the beginning. It was a political compromise, and there was no one really spearheading its advocacy within the federal government. In contrast, the health center program had really strong elite support. So Senator Ted Kennedy of Massachusetts was a really powerful policy entrepreneur and advocated for the program. Then under Nixon, Donald Rumsfeld took over the Office of Economic Opportunity and became a major champion for the program. I'm going to explain why that happened in a moment. Medicaid had very little grassroots advocacy, whereas the health center program from the beginning, because of its social justice progressive goals, inspired a whole advocacy network that grew slowly around the country and is still quite prominent today. Lastly, for Medicaid, many governors and state policymakers didn't like having the federal intervention in their state, similar to what happened for Medicaid expansion under the Affordable Care Act. So the state policymakers themselves resisted the federal government. In contrast, the health center program gained congressional buy-in because it was something that Congress people could deliver to their constituents. They could say, look, I helped you get this funding to open a clinic, and isn't that great? Who doesn't want more access to healthcare? So it was used very differently in a political context. Lastly, on the discursive factors, as I mentioned, Medicaid as a federal state program, and so it constantly was encountering states' rights ethos. In contrast, the health center program was very much focused on human rights. So this is a different sort of discursive framing around the programs. Lastly, Medicaid, as I mentioned, because of its association with welfare, was caught up continually with contestations over morality. So who deserves access to government-funded healthcare, who does not? This was highly racialized throughout the program's history, similar to AFDC or welfare. In contrast, the health center program, because of its buy-in from policy elites, was during the Johnson administration crafted an economic argument that these clinics would provide jobs to the local community. It would stimulate the local economy, and it would also address a fundamental market failure in medicine. So I'm going to explain what I mean by that now. What I found within the policymaking, the rooms where they were discussing these policies, was that there was bipartisan agreement that the government should correct for market failure by incentivizing doctors to practice in low-income areas. There was an understanding that this was a very, the medical profession had a lot of cultural authority, economic power, and political influence. And on their own, doctors would not be incentivized to open their clinics in low-income communities. Therefore, it was the government's job to stimulate that. This was seen as an inevitable feature of how the medical profession operated. This framing by Johnson's policy elites, as I said, crossed party lines during the Nixon administration. So Donald Rumsfeld took up this economic framing, and this grew its conservative support. This framing then became entrenched over time, and they designated what's now called medically underserved areas, which uses criteria to fund clinics in certain parts of the country based on geographic characteristics. This diagnosed market failure in medicine and also reinforced the perception that this was a fair program that was being distributed in a kind of objective basis. And I argue that this economic framing enabled the health center program to circumvent the deservingness debates that Medicaid continually encountered. So this is a way that the program was able to skirt the typical controversy for low-income policies. Here's an example of how this framing was used. So underserved Americans are in the predicament they're in because they have been rejected by the private market. It's not their fault they've been rejected. The government has responded to the failure of market forces to meet underserved and vulnerable populations. If market forces work for healthcare like they have in other sectors of the economy, underserved people run the risk of being redlined, shortchanged, and getting less care than they need or deserve. So this is an example of a typical thing I would see in the archives of justifying the need for this program on the grounds of economic rationale and avoiding the blame of individuals. It wasn't their fault that there were no doctors in their community. okay? So I'm gonna show you fast forward to 1996, when we had welfare reform, and this was a critical juncture between Medicaid and community health centers for a population that is typically highly debated whether or not they are deserving of healthcare. And by that, I'm referring to immigrants. So for those of us who have studied social policy, 1996 welfare reform was a major year for changing the way that we deliver social policy in our country. And a big part of this was adding new restrictions for eligibility for immigrant communities. Importantly, recently arrived and undocumented individuals became ineligible for Medicaid and most other of our large safety net programs around the country. This is a table here from the Urban Institute showing just how arbitrary this was. If you arrived before August 22nd, 1996, you could still access these government programs. If you arrived the day after August 22nd, 1996, you could not. So this is a real big shift in the way that we think of immigrants' deservingness and access to all sorts of public programs. And importantly, I want to point out that different states took different approaches here. So there's a patchwork of services available for immigrants. So some states took up the effort to compensate for the lack of federal eligibility. This is continued to this day. So that's what happened with Medicaid. You might think that health centers would follow a similar path, but in my archival research, I found that they did not. In the years following welfare reform and figuring out how to implement it, policymakers disagreed about what should count as a, quote, federal public benefit. And there's a lot of legal back and forth, all among policy elites trying to figure out what counts as a federal public benefit. This is a document here on the final decision. Elena Kagan was very influential in this. She is now our Supreme Court Justice. She helped come up with the legal reasoning behind it. So they decided to exclude community health centers from this list, which meant that immigrants continued to be eligible to go to community health centers. This is one of the only programs, national programs, that immigrants were still eligible to go. So I argue this is a critical juncture for the two programs and an important population who's often politically contested. The immigrant advocates were crucial in maintaining eligibility for health centers. This separated the health center program from Medicaid and many other safety net programs in our country and how it treats non-citizens. And it meant that health centers were one of few immigrant inclusive institutions in our country. Fast forward to this year. So I think a lot of us have seen these topics coming up in the headlines. Immigration and healthcare are more linked now than they have been in a long time, probably since 1996. Our recent government shutdown, which actually, no, it's still ongoing, I think, technically, although it's looking like it probably will end soon, in large part has been, the Republicans have been blaming healthcare, so Medicaid for undocumented people for the shutdown. This is largely not true. As you saw, undocumented immigrants are not eligible for federal Medicaid funding. This was a falsehood. And the Trump administration has also been ordering states to use their Medicaid programs to try to find undocumented immigrants or people whose legal status may be in flux. So they have been using Medicaid in this fashion. And unfortunately, the health center program has also been affected by this. So that 1998 decision, the regulation about what is considered federal public benefits, is now under scrutiny. So this summer in July, HHS said that they were going to reinterpret that legal that regulation from 1998, which means that programs like Head Start and community health centers would no longer be eligible for anyone to go, regardless of their immigration status. There's a number of other programs that are potentially being affected by this. Importantly, as of September, there was an injunction that paused the implementation of this regulation, but only in 20 states that were included. So it's really unclear what is happening around the country right now whether or not these clinics are indeed serving anyone regardless of immigration status. I'm going to briefly touch on a few of my findings related to this. So before all of this change happened, I've been researching this broader question of how proximity to health centers has shaped access to healthcare for immigrants. This study shows that the health center program has historically targeted immigrant communities. This is largely tied with their focus on the agricultural workforce. So this paper here looks at new immigrant destinations and established immigrant gateways and compares access among those two. Importantly, it finds that immigrants tend to have a closer proximity to health centers than many populations of the native-born population, many parts of the native-born population. Another paper, I looked specifically at the farm worker population and find that living in the same county for agricultural workers living in the same county as a health center increases your likelihood of going to the doctor and reduces your probability of reporting linguistic barriers to care, particularly for undocumented farm workers. The findings are really strong for the undocumented population, which shows that this program has been reaching this very highly underserved community. In my latest work, I've been looking at the effect of community health centers on actual immigrant mortality. So looking at the population health effects since the 1990s, when that important welfare reform change took place. Just to briefly show you a map of, this is the counties in my study that are, the black ones are counties that received a health center over this period. The gray ones are places that did not. And I look at this in different time periods. So looking at when they got a health center and when they did not. I don't want to get too far into the nitty gritty of the study design, but I conduct, oh dear, this is really cut off there. I'm not sure what happened. This is I did an event study, difference in differences event study to look at what happened in a county after a health center opened and basically find that over time, health centers reduced the foreign-born mortality rate in the county where they were located. The effect strengthens over time. Average cumulative effect is negative 64 deaths per 100,000 foreign-born adults over the period of 12 years. If we do a counterfactual analysis, we can estimate that health centers prevented roughly 25,000 immigrant deaths, or roughly that equates to 1.9% of immigrant deaths per year. So this program is having a significant effect on the immigrant population. How the recent policy change will affect that is unclear. So let me wrap up before we switch to Q&A. What I hope you take away from this talk is that the health center program is an important part of our welfare state. It is often hidden. People don't know about it as much, but it is there and it is spreading and growing. Its unusual bipartisan support goes back to the 1960s and early 1970s and allowed the program to circumvent debates over who deserves access to healthcare. In 1996, the welfare reform separated health centers from most other safety net policies by not imposing eligibility requirements for immigrants. As I mentioned, this is currently under threat. And these political processes have population level consequences. Okay, so this is not just interesting theoretically or for our study of public policy, but actual people's lives have been affected by these political processes. We see lower mortality among the foreign-born population if they have access to a clinic in their county. This, I argue, demonstrates the efficacy of having inclusive public policies and this how it can affect population health. On the other hand, it also suggests the potentially dire consequences when the state withholds access to resources like healthcare. And unfortunately, in the years to come, I will be studying what this recent policy change could mean for immigrant health. So in closing, I leave you with the words of Edna Tate, who is a community health worker in Atlanta. This is from a hearing on Medicaid. She says, the right to health care for every citizen is probably the least controversial of any of the rights men have sought through the ages. Controversy does arise, however, over how to best secure the right to every individual. Community health centers are a really important part of our country's delivery of healthcare to people, regardless of income, immigration status, insurance. But they're only one small piece of that puzzle, and we need to continue working on this issue. So with that, thank you so much. I look forward to your questions and comments.
We have about 25 minutes for some Q&A. I'll start us off then. So, so can you give us some indication of the comparative budgets between the community health centers and Medicaid? And also, were they affected or impacted at all by the Big Beautiful Bill?
Oh, great questions. Your first question is very time specific. In the early years, the health center program had a much bigger budget because they were funding all sorts of non-medical activities. So they had really high grants. So for example, one of the clinics in LA received $1 million a year in 1966 dollars. So that's a lot of money. During the Nixon administration, they reduced the budget quite a lot. So the overall budget became much lower, much more, which definitely affected its political support. Medicaid, on the other hand, grew astronomically at the very beginning, far outpacing what they expected it would. And so this definitely contributed to its lack of political support. In recent years, it's really hard to disentangle because so much, something like 40% of the health center program's revenue comes from Medicaid. So a lot of Medicaid funding is going to health centers. It's hard to disentangle, but Medicaid has always been a lot more expensive than health centers. I can't give you like the exact numbers. I might have that somewhere in my notes, but it's always been a lot more. For your second question, the Big Beautiful Bill. So they are not being directly impacted. So they were left off of any sort of changes to federal policy, but via Medicaid, they're going to be hurt a lot because so much of their funding comes from Medicaid. So they rely on
What percentage do you know comes from Medicaid?
It's close to 50%. A huge portion of their patients are on Medicaid. So they will be hurt. I've already heard of health centers that are closing in anticipation of the Medicaid cuts. Typically, they try to close some of the satellite clinics first and hopefully keep the main grantee organization, but it is being indirectly affected. Their finances are very much at risk. And not just from Medicaid cuts, I should say, but just the growing, the expected growth in the uninsured population next year. There's many reasons why health premiums are going to go up for a lot of people, and so people are worried that that's going to mean that our uninsured rate goes up. When people are uninsured, they tend to go to health centers because they have a sliding scale fee structure. So if you have no insurance, you can get cheaper care. Yeah. Dylan.
Can you go back to the discursive slide for a minute? Sorry, I know it's like a journey here.
Yeah, that's fine. This one? Or the earlier one?
Yes, I think this is right. Oh, actually, can you go back one more? Sorry.
This one.
Yes. Mm-hmm. Okay. It is intellectual gobbledygook for anyone to claim that a community health center program is correcting a market failure, but that government provision of health insurance is not.
Yeah.
That's like nonsense. I'm sure we have some economists in the room who would maybe disagree with me. I don't understand how it's possible that one can get constructed in a way that we're fixing a market failure, we're good free marketeers,
yeah,
and the other isn't. And I'm curious if you can talk more about like the roots of that and how it's possible that there could be such an intellectual disconnect on Medicaid with that, but not with community health centers?
Well, so most of the issue there is the institutional attachment with welfare, which had a lot of baggage going back decades at this point. So once there was that initial decision that you'd only be eligible for Medicaid if you were on welfare, that immediately created a different conversation around Medicaid that could not really be addressed by a kind of sound economic reasoning. In the 1990s, policymakers did put more effort into creating an economic argument for the benefit of Medicaid and its role in market failure. Many people who are on Medicaid are working, but their employer does not cover their health insurance. So that is a very strong economic argument in support of Medicaid. By that time, the politics were so entrenched. So that's why it's really important to think about like the very early period of policy discourse. That's really when it matters the most because these have path-dependent long-term consequences. So yes, in my work, and in fact, many economists do argue that almost every government intervention can be thought of as addressing a market failure. That is how we justify our intervention in any sort of capacity in our country during the neoliberal era. This is how we justified government intervention. So yes, this was a intentional choice. Maybe intentional is not the right word. This was a cultivated conversation that was happening among policymakers around one policy, but not the other. And largely for Medicaid, had to do with its association with welfare. Yeah. But it's a great question and thinking about why more policies are not seen this way, even though they are correcting for market failure.
Sure. ACA
Yeah.
was the Republican free market platform for
Exactly.
healthcare.
Yeah.
Right? And then every Republican voted against it.
So the time and period matter a lot for these things. So I argue that this early on discourse, this was like right at the beginning of what we think of as the neoliberal era, set the health center program on a different path. That then other programs since then have also followed a similar trajectory. Yeah.
Does it matter that community health centers, you could frame community health centers as being for the community, whereas Medicaid is clearly a benefit for an individual who may be deserving or undeserving?
Yes, so the role of place. Yeah. Place versus people is very, very important in this. Community health centers were fixing a problem with a lack of doctors in a place. And it wasn't the fault of people living in those places. Medicaid, though, it's an individual benefit, but it pays for doctor services. So it's not exclusive to the individual, which is why for those of us who've studied different poverty measurement, Medicaid is highly controversial. Should it be considered in kind or not? Because it's not something that you can actually use to spend money. It's paying for the provision of services. Yeah. But the difference between targeting people versus place is fundamental difference. Yeah.
Since we're almost there, could you go back to the political factors?
Yes, of course.
One thing I was curious about, is there any difference in the interest group support for these two programs?
So this was a really interesting finding, and some other scholars have also argued this. Once Medicare and Medicaid were passed, the power of organized medicine was greatly diminished. So by that I mean American Medical Association, who had been very influential in preventing national health insurance from being established in this country. So organized medicine was definitely weakened, which positively affected both programs. So there's little resistance. There's some resistance for both, but on the part of the medical establishment, they saw both programs as ways that the government would pay them for charity work. So it was not a big difference in interest group support. However, the advocacy networks were very different. So Medicaid, there's no effort to grow some sort of grassroots advocacy coalition to support and defend Medicaid because progressives at the time thought that national health insurance was the bigger fight worth kind of organizing for. So Medicaid was kind of left off the table to be replaced.
What about big business groups? We know that Obamacare is loved by Walmart because then they don't have to provide health care.
Yeah. Yeah, so, okay, so you mean, so in more recent times?
Well,
Yeah.
I was curious about the difference with these two programs.
Well, Medicaid is a huge, yeah, they have a huge, huge backing among a lot of powerful healthcare actors because they do pay for groups that the private health insurance industry doesn't want to cover. These are higher risk populations that, so private health insurance, hospital industry, other powerful parts of the healthcare industry are nowadays much more supportive of Medicaid and kind of reeling from the summer's cuts that are going to be coming. The health center program doesn't really have its own kind of organized interest group. They have their own, advocacy group that connects with policymakers in the government, but they're not as affected by the bigger healthcare actors. Yeah.
Got a question from one of our online viewers here who asks, how do rural hospital districts such as Pullman that are governed by local elected board members in the state compare to the health centres?
Oh, I didn't realize that. Your local hospital is community governed. Okay. That's probably following a very similar model to the health center program. Yeah. So it has to be at least 51% of members of the board have to be patients of a community health center, and if that's how your hospital is run, it sounds quite similar to that. Yeah. So they probably use a similar model. I'd love to hear more about it if anyone knows about your local hospital.
Going a little bit away from the big picture,
Mhm.
macro politics, and thinking about individuals,
Yeah.
I'm a little curious about your qualitative findings
Uh-huh.
and particularly so I'm trying to think about the benefits of having access to healthcare that's not stigmatized, but then the drawbacks of having people not know that that's part of a larger
Yeah.
safety net, and then as a result, maybe not even support federal government intervention and programs.
Yeah.
So could you speak a little bit to that and would it be more ideal to publicize more the government intervention in these programs, and then is there a way to not make it stigmatized? when you do
Right.
that?
Great question. Political scientists have written extensively about this and the kind of tensions at play here. In the particular center where I did my research, it was in the Rust Belt. It was predominantly white, predominantly very conservative as well. So when I would talk to the leaders of the health center, I'd ask, once I learned that people didn't understand this was a government program, I'd ask them, why not? Why don't you think? And they would answer quite honestly, it's not a big selling point for us to advertise government. So it's not only that it's kind of part of the design of the program itself, but it's also choices made by the organization and how to communicate and advertise their services to their community members. So they intentionally didn't have government written all over their website or all over their office. So when you went in, it wasn't clear that this was a government program whatsoever. But then what happened is many patients who I talked to, at the end of the interview, I'd say, look, do you know this is part of a government program? They would almost always say no. And when I'd explain what sort of benefits that it could entail, they would say, oh, I wish I had known that. I haven't gone to when I had an overdue bill, I didn't go because I didn't think I could. So in fact, they can go and no one can be turned away from a health center. That's part of their federal mandate. And so I found that this did, for some patients, mean that they delayed going to the doctor or just decided not to go at all. So there's real tension here between, on the one hand, not feeling stigmatized in your clinic when you go to your clinic, which is potentially a positive thing, and other sorts of delegated policy designs may also have this effect as well. So the earned income tax credit, there's been some research that also finds that people don't feel as stigmatized using the EITC as they do using cash welfare. So there's analogs as well. But for this program at least, I also found there are some downsides for the patient perspective and may reduce a sense of social citizenship and that they have ability to demand rights in this setting. And if they knew it was a government program, maybe they would.
Can you talk a little bit about, this program has had consistent bipartisan support, especially in the early years, Nixon administration, others. But we know that the Republican Party today is not your father's Republican
Yes.
Party.
Yes.
And so I'm wondering what's going on in the Trump administration with this. I mean, is there animosity to this program, or is there any support for it?
Yes.
Or okay, all right, go ahead.
Yeah, so I want to make a caveat here that nothing is ever permanent. We see things becoming politicized that we never thought would become politicized. A few years ago, it was the post office all of a sudden became something that we thought was politically neutral became politicized. So it's very possible that the health center program could also lose its bipartisan support. I don't think that will happen, again, because of this constituency effect where people, Congress members, like being able to deliver the service to their constituency. They like to say, look, I voted on the measure to increase funding for this program so that your clinic can get upgraded, or you can open a new one in the neighboring village, that sort of thing. So there is a lot of buy-in because of what it delivers. And of course, a lot of research shows that once you give something to people, it's hard to take it away. And so they don't see any sort of benefit, as far as I'm aware, in taking away these services. The way that it's being affected is through Medicaid cuts.
I want to link that back to the previous question because I'm sort of curious to know how that works if people on the ground aren't really aware of the program, right? I found similar things with regard to the ACA where people I've interviewed will say, you know, that they hate Obamacare, they think it was terrible. And I say, oh, so you don't have healthcare? And they'd say, well, I'm on AppleCare, which is the ACA in Washington State, right? Which I would think would make it sort of politically more vulnerable, right? Because they don't understand this connection that as we're cutting the ACA, they're not thinking about like, oh, it's gonna cut my healthcare. They're thinking about that poor person on welfare.
Right.
So if they're not aware of these clinics being government supported in the first place, does it matter where they're
Great question. So when I would ask them about their views of the government and vis-a-vis this program, they always would bring up other programs too. Oh, this isn't like going to the county welfare office. This isn't like you know, getting housing assistance. And they would contrast this with what they thought of as the government, right? When I would explain that this is part of a government program, they would usually say, "Oh, that's great. That makes a lot of sense." These are people who are by and large very conservative, but they say, "Well, we don't have doctors in our rural area. We need them. This is the role for government. This is appropriate." And in the, I can't disclose where I did the research, but in that state, there also were Medicaid programs that had different names, which is another way of reducing stigma. But a lot of political science research has been suggesting that this is part of our political conundrum right now, that we are not giving credit to the government when it is helping us. And what that means when these services go away, unfortunately, is I think it'll be a really tough wake-up call for a lot of people in the ways that they have been, that the government has been benefiting their own personal lives. And it's really unfortunate that it takes, losing something to appreciate the government, but potentially there's a lesson there for us in the future that we don't necessarily want to hide all the ways that the government is helping us. Good question.
Just a quick, there's a clarification and a little question here as well. Our online viewer went on to say that in Pullman, it's a county hospital district,
Okay.
not just the city, and that all members must live in the district. So they've all got to be in the
Oh,
county.
interesting.
And then I wonder if you could talk a little more about the red states and whether they're overrepresented with CHCs and how that might play out going forward.
Yeah, this is an area of research that I plan to continue. I'm sorry, I feel like I've been ignoring this whole section. I've been facing all of you. But yes, this is an area of research that I think is really, really important for exploring potential, particularly with the Medicaid expansion states versus not. That's something that's an area of research that I have started doing as well. So we do see some states, such as Texas, which is also where President Bush was from, during that period saw some of the biggest growth in health centers, so around the state. And so it's often been used as a way to kind of put a Band-Aid over the broader problem and say, look, we're going to deliver you a clinic. We're going to bring a clinic to closer to your home, but we're not going to advocate for broader health reform. So this is actually, even George H.W. Bush was started this trend in the late 80s of saying this is a kind of minor fix to the broader problem. And we're just not going to touch the broader health, lack of health insurance problem, but we are going to provide more delivery services. So red states, although state policymakers are not involved in the grant-making process, so to clarify, local organizations need to apply for a grant to get health center funding. States are not necessarily part of that decision or the application process, but if some states come together like Texas and provide more resources to get those grants into their states, then they can see more funding. So I think certainly in the past and in the future, we're going to see state-by-state patterning to make up for the lack of Medicaid coverage. Yeah.
Okay, we have time for one more question, if there is one.
You have gone through a lot just pertaining to this program. What do you think would be your primary message? Like, what is the main thing that you want us to take away from your presentation and through all of your quantitative research? Like, I'm sure that you've talked to many people and you've gotten many places and you've done a lot of things pertaining to this specific topic. Like, what do you want us to take?
That's a great question. What I think we should all take away is that this is an important program for ensuring that we have some way of getting healthcare in this country. It is one of the few places that we do provide healthcare as an entitlement, as a right. It's walking in and saying, you can get treatment. How much healthier would our population be if everyone could just get access to healthcare without having to live near a center that provided sliding scale services, for example? So I want you to think about what it means to have an exception to a broader pattern and the sort of population health consequences if we did provide healthcare as a right to everyone. That's I think the big picture for moving forward in our country. Obviously, seeing a lot of debates over access to healthcare today, this week, the last few months. It's been a big topic. We're going to see a lot of people losing access to insurance in the coming year or more. And so potentially it's time for us to have a broader conversation about rights to healthcare. So thank you all for your comments and feedback. I'm happy to continue talking with
you. Let me remind you before I thank our guest again. Let me remind you, our last event this semester is going to be on December 3rd at 4 o'clock. We're taking the week off next week, and then it's Thanksgiving, but the week after that on December the 3rd, we have Michael McFaul, who is former U.S. ambassador to Russia. He's now a senior fellow at the Hoover Institute and a political science professor at Stanford. He'll be talking about his new book that just came out called Autocrats and Democrats, Russia, China, the United States, and the New World Disorder. So let me remind you to come to that. That's the last in our series on the future of liberal democracy. But now, join me in again thanking Emily Parker for sharing her research with us and a really interesting conversation. Thanks.
Thank you.